Слово у нас предоставляется профессору Гнанту, пожалуйста. Его доклад будет посвящен предиктивным маркерам в отношении ранних и поздних рецидивов рака молочной железы. Пожалуйста.
Good morning. Madam Chairperson, dear colleagues, thank you very much for the invitation. I have to apologize, my Russian is very poor, so I have to give this presentation in English. And I'm going to address a little bit what has already been discussed. How can we assess on an individual basis the risk of relapse in early breast cancer, and subsequently how can we predict the response to treatment. So this is my home institutions in Vienna, and there is this clear-cut connection of assessing prognosis, as we do with classical parameters, as we increasingly do, and I'm going to show you with molecular tools, prediction of treatment effect, because what we now do is we probably overtreat the majority of breast cancer patients, because if they are hormone receptor positive, they all will have endocrine therapy. If they are receptor negative or high risk, considered high risk, they will all have chemotherapy. So eventually everybody gets everything, which is overtreatment, huge burden to patients, but also a huge burden to society in terms of cost. So this is how we nowadays assess this in a multidisciplinary tumor board. So you see the tumor board of Vienna, all the surgeons and everyone sitting around. Obviously that's me here. Whether you do it on an individual basis or you do it in a group, it's always the same questions. And this is what we are considering. Estrogen receptor content, progesterone receptor content, if you have it available, histology grade, some markers of proliferation, Ki67, with all the problems of standardization. Obviously, in early breast cancer, we still use the nodal status of patients a lot, and we have vascular invasion, T-sites. So this is what actually the St. Gallen consensus has been using until recently. But even these classical parameters are not without problems. As you know, measuring the estrogen receptor content, even among very skilled pathologists, is not a perfect 100% overlap. We have to estimate about 30% inter-observer variability in published studies. And that means that in clinical practice in the community setting around the world, the heterogeneity of results may even be higher. And just given in this example that this actually directly impacts on patients' treatment, let's assume you have a wrong determination of estrogen receptor. Eventually, as a clinician, you will withhold the optimal treatment from this patient. Well, let's assume that you have like a false positive HER2 status, and then you treat the patient with all the expensive drugs, but it is for nothing basically. It doesn't have any efficacy, only side effects. So the background of dealing with more modern molecular tools is that we need to clarify this undertreatment versus overtreatment issue. Hopefully at some point giving us the opportunity to actually assess an individual patient's risk of metastasis, because if there is no risk of metastasis, then there is no reason for treatment. I'm going to show you some data which may in the future help us to get better in doing this, be less reliable on nodal status. I realize that this is not an issue obviously in metastatic breast cancer, but in early breast cancer still nodal status is mainly used as a result most node-positive patients, even if they are endocrine responsive breast cancer, will receive adjuvant chemotherapy. And I can tell you, patients don't like this. And there is a number of genomic tools which have been reported, so everyone knows about the Oncotype and MammaPrint and a number of others. I'm going to introduce you some clinical data on a now also approved RNA-based assay. It's called Procinia in the United States. So recently had approval, and it's based on the PAM50 score, which the previous speaker has already introduced based on Chuck Peru's work about 10 years ago. The idea of these RNA-based assays is, and that's different to Oncotype, that they should actually not be done somewhere in a central place in the United States, but these assays should be performed in a decentralized basis by the pathologist in the academic or community institution. So I'm a surgeon by training, but I don't want to cut off my pathologist from the diagnostic process. So I think that's, in terms of strategy, the optimal approach, that we have a tool which, at least in the end of the development process, will be available to everyone. The PAM50 has been shown in the ATTACK trial to provide more prognostic information than Oncotype's recurrence score. And I'm going to show you some of these data. So this is how such a test is developed. Basically, we had this research work, subtypes of breast cancer, luminal A, luminal B, basal-like or triple negative, which is not quite accurate breast cancer, and obviously HER2. And then a gene signature involving approximately 50 genes was developed and validated. It's then important to select a platform and to have an analytical validation process. And now, since last year, NanoString has received approval in Europe for using this, and this year in the United States. So this is just an example of genes that went into that algorithm. And what happens is that it is important that this is reproducible. So it's important that multiple pathologists review the tissues. It should be done by a technician everywhere in the world, and it needs to be very reproducible. And I think this is true for all the tests that come to the market. As a clinical scientist, to me it's important that there is a good clinical validation of these tests. Some of them may just be more important methods to identify what we can do with classical pathology. So the overall goal of the work we have done in ABCSG is to determine whether the PAM50 test is actually adding something to the classical clinical and pathological parameters of nodal status, estrogen receptor, Ki67, and all of that. And we also wanted to demonstrate that this can be done in a decentralized basis. So you may have heard of the clinical trial ABCSG8, recently published in the Journal of Clinical Oncology. So that's postmenopausal breast cancer patients, low risk, overall low risk. There are no high-risk patients in this trial, and they were randomized to have 5 years of tamoxifen versus 2 years of tamoxifen followed by 3 years of anastrozole. So this is a low-risk group of patients where you would consider not giving chemotherapy to everybody. We had to reconsent these patients for this study because of the Austrian law. The median follow-up of this data is now a little over 11 years, which I think is pretty good. And this is what you can see. We managed to obtain 1,600 pathology specimens. And more than 90% actually, even some of them being 15 years old, could be successfully RNA extracted and put into the validated assays, which I think is an excellent quality, demonstrates an excellent quality of the assay. So the primary question was, there is this risk of recurrence score, which is the result of this. Does this add something to the clinical treatment score, which is a score of nodes, grade, tumor size, age, and other things? Some complex statistics involved, and the plain answer is yes. This is a huge chi-square. We can, using this molecular tool, get some additive information, and I'm going to demonstrate this to you in survival curves. So again, this is a low-risk group of patients. This is 10-year results. All patients have been followed at least 10 years. And you see that they're within these low-risk groups of ER-positive patients, there is this low group with just a little over 3% overall relapse risk at 10 years. There's another group, 10% relapse risk at 10 years, and there is the high-risk group with 20%. So I think it is fair, most of us would agree, that if we look at a 10-year relapse risk of just 3%, then we will probably not consider adding any toxic and side effect-rich adjuvant treatment. This might be different in a patient with a clear-cut high risk of 20%. Next question we asked, how about the subtypes? We have already discussed today the luminal A and luminal B subtypes. Does this work as well? And the answer is yes. When you use the PAM50 to identify luminality, you can see that, in fact, luminal A patients look at a much better long-term prognosis than luminal B. This is not new, but if you can individualize it beyond the classical parameters, then this might as well in the future guide your treatment. And the intermediate summary is that, in fact, using this new molecular tool, we could accurately make a prediction of the 10-year distant recurrence rate, which I think is a very important factor. And this would be adding information to the classical clinical parameters. Now, another issue which we investigated was the issue of late metastases. I think that for a long time, we as a scientific community and as clinicians have not been very honest with our patients, because when I started studying, patients were informed that, you know, you get 5 years of tamoxifen, basically after 5 years, you know, that's it, that's fine, which we now know is not true. Particularly luminal breast cancer, particularly highly estrogen receptor positive breast cancer is a chronic disease. We will see as many recurrences between years 5 and 15 as we do in the first 5 years. And even those low-risk patients keep having relapses after 10, after 15, after 20 years. And very obviously what we try to do is we try to extend the duration of hormone treatment, which again extends the side effects and the cost for society. You know these trials, the MS-17 with letrozole, NSABP has done a trial demonstrating that when you extend treatment with aromatase inhibitors, and we have done the same in ABCG6A, and the results are very much the same whether you use anastrozole or letrozole or aromasin. It's about the reduction of metastases by 30 to 40% when you keep patients on an aromatase inhibitor. Very recently, we have seen tamoxifen extension data from the ATLAS and ATOM trial yielding very similar results. So now the question is, do we really have to tell every patient, well, keep going and use these drugs for prolonged durations? Or can we use, again, the molecular signature to predict what the late metastasis risk is? And this is what we did here, and I will just quickly jump to the results. As you can see on the x-axis, this curve starts at 5 years, and it goes out to 15 years. So this is really reasonably long-term risk. And what you can see is that, again, the low-risk group, at 10 years, whoever is without relapse at 5 years, so this is where we nowadays usually stop treatment, Some patients have an extremely low risk of later metastasis, less than 2% at 10 years, and less than 3% at 15 years after diagnosis. This is a patient I will not suggest to have extended adjuvant therapy. There is an intermediate group, and there is the high-risk group, and you see that these patients actually look at the 20% risk of metastasis between years 5 and 15. So this is quite substantial. That's probably patients where we should consider extending the adjuvant therapy. Even more impressive, in the node-positive subgroup, this is weak because there is a limited number of events. I'm going to address this in a minute. But you can see that there is node-positive breast cancer patients who are actually at low risk to have late metastasis. So the metastasis risk of these low-risk patients, despite they are node-positive, is 0. If my metastasis risk is 0, I will not take any more drugs after 5 years. Obviously, there are other patients in this situation as well. And as a result, we can identify, using PAM50 as a molecular tool, that there are certain groups of patients, and this is the annual risk of metastases within the first 15 years. And what you can see that some patients have a very high early risk. This is probably driven by genes of proliferation. And this is what we usually address with chemotherapy. So that's definitely the subgroup of patients who should receive adjuvant chemotherapy despite being hormone receptor positive. There is this intermediate group of patients who have a limited early risk, just 1% per year, but they have like this late peak. If you could look at this, this is 11 or 12 years after diagnosis. All of a sudden, 2% of these patients will suffer a distant relapse. So that's not some local relapse, which you can easily cut out. This is metastasis, and it means incurability. So these might be candidates for extending the adjuvant therapy. And then there is this low-risk group of patients where actually throughout the whole continuum of 15 years, the risk of relapse is lower than 0.5%, 0.5%. And I think these are patients where we can consider not giving them adjuvant chemotherapy and definitely not using extended adjuvant therapy. So about these tests, there is several data. Oncotype, in terms of late metastasis, actually failed. Last year's San Antonio meeting, Terry Mamounas presented some data. It simply didn't work, which is clear if you look to the science, because Oncotype is mainly based and driven by proliferation genes, and proliferation is not important for late metastasis. There is no data for Mammoprint. The IHC, which was pushed a lot by my friend Jack Cusick and Mitch Dowsett, does not provide additional information for late metastases. The Breast Cancer Index does. Very interesting paper by Dennis Croy in Lancet Oncology just a couple of weeks ago. We have also done something with a test called EndoPredict, which is also predictive for late metastases, and the PAM50, nanostrings PAM50, as we have demonstrated earlier this year. And I think this is the current schedule of trials of extended adjuvant therapy. You see, there's 20,000 patients worldwide. We do a trial of 7 years versus 5 years. The Canadians do a trial of 15 years of therapy. There is the very interesting SOLE concept, interrupted letrozole, trying to utilize estrogen hypersensitivity of dormant tumor cells. And there is other trials, so that field of extended adjuvant therapy is going to become very, very important in the future. And molecular risk factors might be very important because, and when you look down here, when you have a metastasis risk in a low risk of, let's say, 1.3 or 1.2%, then I think it's fair that these patients can be spared adjuvant therapy. I'm going to give you, in ending, some information on, particularly on node-positive patients. Because many of us will be prepared if you have a very high estrogen receptor content in the tumor and you have no negative nodes, then many of us would probably not consider adjuvant chemotherapy. But if the nodes are positive, then still around the world most people get adjuvant chemotherapy. And we have teamed up together with the ATAC trial in trying to identify particularly this node-positive patient subgroup. So this is started with over 2,400 patients, about 1,000 patients from the ATAC trial, and about 1,500 patients from the Austrian trial. And we wanted to identify, can we find, using PAM50 and the nanostring assay, additional prognostic information specifically in patients with 1 positive node, with 2 positive nodes, or 3 positive nodes. So out of these 10,000 patients, eventually we had about 2,500 specimens. Out of these, eventually 638 were node positive. A number of them had to be excluded because a high number of positive nodes. So this is 543 patients from the ATAC trial and from ABCHG8 with 1 to 3 positive nodes. And this is the result, again using the low, intermediate and high molecular classification by NanoString's PAM50. And what you can see is that in the high risk group, node-positive patients, this is 30% risk of metastases, all node-positive patients together. However, there is a low-risk group here of about 1/4 of patients where you can see that, well, this is less than 10%, just 7.9%, which most of us would be considering low risk, and these are candidates for not having chemotherapy. Same story with intrinsic subtype. Luminal A versus luminal B. The luminal A patients end up with 11% metastasis risk, luminal B 31%, so a clear-cut difference here. And if you construct a table of this in terms of risk group, if you are low, risk of recurrence group, risk group low, as determined by NanoString's PAM50, 1 positive node, 6.6%, that's definitely low risk at 10 years. 2 positive nodes, even 2 positive nodes, only 7%. I will not treat the patient with adjuvant chemotherapy if I know that this is a 7% risk of metastasis, even when there are 2 positive nodes. And in terms of the intrinsic subtype, at least for those with 1 positive node, luminal A patients just look at 8% 10-year risk of metastases. I think that, and I will jump to the final sentence of my conclusion here, that based on this particular low risk, some of these patients could be spared the side effects of adjuvant chemotherapy, which can, despite being node positive, eventually obviously save a lot of harm from these women, address the overtreatment catastrophe, as I call it, and eventually also save a lot of money for insurances and healthcare systems of the public system. Thank you very much for your attention, and I'm obviously prepared to take questions.
Thank you very much for your interesting lecture. Какие вопросы есть, коллеги, к профессору? Но вообще мне бы хотелось задать все-таки 2 небольших вопроса. Скажите, пожалуйста, все-таки вот вы сейчас в своей практике определяете риск развития прогрессирования заболевания и какую химиотерапию, в какие сроки вы будете рекомендовать больным с люминальными формами рака молочной железы?
In early breast cancer, if we use adjuvant chemotherapy, we usually use anthracycline-based regimens if the patient is node positive. Node negative, I'm sorry. If the patient is node positive, we will use anthracyclines followed by taxanes, 6 to 8 cycles, depending on risk. We do this immediately after surgery, and we postpone radiotherapy to after the third or after the final chemotherapy cycle.
И еще один вопрос. Скажите, пожалуйста, хорошо известно, что в каждой стране свои стандарты. Вот для Австрии на сегодняшний день для гормон-позитивного рака молочной железы какие приняты стандарты? То, что будет выполняться каждой пациентке в обязательном порядке, какой объем лечения она может и должна получить?
So we have guidelines, and we have a penetration of the guidelines, so to speak, of about 90%. So we have data on a national basis. It's a little bit easier because we're a very small country. We know whether patients are treated according to guidelines or not. Something like endocrine treatment for ER-positive breast cancer, or obviously chemotherapy for ER-negative breast cancer, or chemoimmunotherapy with trastuzumab for HER2-positive breast cancer. And the adherence to these guidelines currently is about 90%.
Спасибо. Коллеги, да, пожалуйста.
Профессор Гнан, спасибо большое за очень интересное сообщение. Крайне важные данные для клиницистов. И все-таки были представлены результаты использования ПАМ-50 для определенной группы пациентов, клинической группы постменопаузальные женщины N0, N1, рецепторный статус положительный, и исключаем G3. Можно ли, имея дополнительную информацию, иммуногистохимическую, рецепторный статус HR2, Ки-67 и так далее, эту выборку сузить для использования ПАМ-50? Ваши рекомендации, ваш взгляд?
That's actually a very intelligent question, because we will in the future probably use these assays not for everybody, but only for those with discordant information. We are currently working on doing some research for Ki-67, but as you know, as I do, you will have, let's say, at least 1/3 of patients where your proliferation is between 10 and 35%, which is then again an intermediate Ki-67. It's easy if you have 90% proliferation, and it's easy if you have 5% proliferation. But a significant proportion of patients will have something between 15, 20, 25%, and you still are not helped with, for example, for the chemotherapy decision. So I think eventually it will be a proportion of, let's say, 30 to 50% of patients where in clinical practice we will utilize the new information, not 100%.
Спасибо. Еще есть один вопрос, Виктор Алексеевич, пожалуйста.
Доклад. Скажите, пожалуйста, а работает ли ПАМ-50 при поражении лимфоузлов 4 и более?
Another good question. These 4+ patients have been excluded from the analysis. There is some preliminary information that this might work, but this is scientific, this is not for clinical practice. If a patient has 4 or more positive nodes, in most places around the world, patients will get chemotherapy anyway, so it may be less important in that sample. I would, however, agree with you that with respect to the long-term treatment, what to do with a patient with 6 positive nodes who does not have relapse at 5 years. And we have, as I have shown you, we have some of these patients who don't have any late relapse risk. So maybe in the future this may also be an important tool for patients with a large number of nodes.
Спасибо большое.